and legislative support for C&D process so that we can have a legal backing for the process and generally the MPDSR process. That is very necessary for a successful C&D implementation and also MPDSR implementation in the country. The other recommendation was to strengthen MDSR notification. So generally improve MPDSR in counties so that we can have processes going on as required, committees being present, making the right recommendations, and also following up actions after the recommendations. The other recommendation was to standardize documentation. So one of the findings was that there were challenges in documentation, and I think Martin has highlighted that. And with regard to this, there was to one of the other recommendations was to explore use of electronic medical records. The other issue or the other gap that had been identified was the diagnostic services. So the recommendation was to expand this with a focus on improving the diagnostic tests, especially at the point of care, maternity and labor ward. And then also the other recommendation was to improve blood supply, that is in form of blood itself and other products of blood, and making or adopting innovations to improve blood and blood supply. The other recommendation was to provide up-to-date treatment protocols, and especially those that were user-friendly, so that the maternity healthcare providers could access the treatment protocols easily and be able to provide the treatment accordingly. The other was to embrace use of technology, and some of these recommendations also touched on what the county was to do, and that is why we have now the national and county level. And mainly here was capacity building in terms of EMOC training, and also capacity building especially at level 4s, where we found quite many challenges and many referrals coming from that point. Building capacity in terms of spinal anesthesia. And then retention, I think we discussed that yesterday quite broadly, where you train health workers, but then the retention is a problem. So again, this was a recommendation to make sure that the staff that are trained and that have the skills in maternity are retained, and at least for 2 to 3 years, so that they can provide the necessary expertise. And then the other was to also make sure that we have competent and experienced healthcare providers at the point of care. It was one of the challenges and one of the gaps that was reported in that CMG was that the availability of staff, experienced staff, was a problem at the point of care. So staffing with experience and competent staff was recommended, and also ensuring or exploring how to do this model of remuneration, especially in areas where we have challenges of the healthcare or the experienced specialized healthcare providers like obstetricians. And the other was documentation, which again Martin has mentioned is a major gap in terms that was identified in the CMP process. Now at the county level, one of the recommendations was to strengthen the availability of comprehensive emergency obstetric and newborn care, but also basic emergency obstetric and newborn care. So facilities are there, some are referred to as CMO, others are referred to as EMO, but they are at different levels of functionality. So one of the recommendations was to increase this up to greater than 70%. So adopt strategies to increase, including performing EMO functionality assessments, to assess and after that take action to ensure that our facilities are well equipped in terms of providing comprehensive emergency obstetrics and also basic emergency obstetrics and newborn care. The other was capacity building, as I mentioned, and then availability of specialists, mainly here the obstetrician, improving documentation, I mentioned that, and then linking maternal newborn health to critical care. One of the findings was there were challenges in mothers accessing intensive care, and that is where that recommendation was made. At the facility level, the recommendation was to provide minimum package for antenatal, postnatal, and then improve the monitoring of ANC labor and behavior. One of the gaps identified again were challenges to do with monitoring of also conducting of regular audits and giving feedback to the health workers so that they can improve the quality of care. At the community level, the recommendation was to strengthen community limits by improving the facility linkages. Again, this was a method of improving the MPDSR process because there was, or it was identified that there were many deaths that were occurring in the community. And providing this linkage would provide, to make sure that the process is complete so that the deaths that are happening in the community can be reviewed at the community level, but then reported by the leading facility. And then strengthening immediate reporting, mainly through verbal autopsy. So as I said earlier, I'm going to limit my discussion or my presentation mainly recommendations that were implemented at the national level. So the first one, providing relevant policy and legislative backup for CMP process and generally MPDSR process. Now here, I would say that this area we still have a lot to do. It is in work in progress. The enactment of the MNCH bill and the gazettement of the National MPDSR Committee is still work in progress. The vision of reproductive maternal health is still working with this. But again, these areas or these challenges also rotate with regard to the challenges that we are having with regular meetings of the National MPDSR Committee. But however, the Constitution provides an environment, a good environment for quality reproductive health services. But I would like to emphasize that this bill is very important so that we can anchor CMD process and general MPDSR process to the legal framework. And then the National MPDSR Committee, as I say, when the appointment was done, the assessment has not yet been done, and this needs to be done. And also there was recommendation that we need to include female advocate or a judge in the committee. Again, this is work in progress. This has not been implemented. So this is a very important point or recommendation for us to have good progress as a nation. The next recommendation was to strengthen MPDSR notification and general MPDSR. Here, a situation analysis report was made in 2019 regarding the MPDSR implementation in the country. So assessment was done generally in the counties, and of course, different counties were in different levels of implementing MPDSR. And after that, the Division of Reproductive Maternal Newborn Health engaged in capacity building of the committees in, so as to strengthen them and to make them functional for MPDSR process. And still, as part of implementation, the DRMNH developed the National MPDSR training package so that the training in the country was to be standardized so that what is happening in Isiolo can be what is happening in Mombasa, and to make sure that that was sustainable. 64 national trainers were trained, and these are spread in all the counties. And currently, work has been going on. These TOTs have been instrumental in implementing, in training healthcare providers in the counties with regard to implementation of MPDSR. Then printing of MPDSR tools have taken place. Many counties have already collected their tools, but we still have some still to collect at the Division of Reproductive Maternal Newborn Health. The tools were similarly reviewed, so we have new tools that have been reviewed, and these are the ones that are being distributed. And again, updating happened at the KHIS, so that what was reading in the tools, the hard copies, is what was also reading in KHIS system. The other recommendation was to improve the quality of documentation, and here a two-day stakeholders meeting was held, and the intention was to review the maternity file and also the newborn file to make sure that we have standardized files, because as it is, different counties and different facilities, even in the same county, different facilities have different maternity files and newborn files. And this was a way of improving documentation so that we have standardized admission forms, history and examination details, the idea was to improve documentation, and again by extension to improve the MPDSR process, because as Martin mentioned, an improved documentation will also give quality data to MPDSR process, so that what we analyze and what we report is the actual situation. And a QOC, the quality of care standards that was developed, has established the documents that must be there in maternal and newborn health services. So this document is existing, it is developed, and it establishes the standard for the documents that we require for maternal and newborn health. The other recommendation was to have regular and mandatory updates on EMONC. This was one of the recommendations. And at this point, most of the counties are now conducting EMONC trainings. There is an EMONC training package developed by the Division of Reproductive and Maternal Health, and this is what they are using to train their health workers. We already have the trainers in the counties, and they are also anchoring the training of EMONC into the annual work plans and budgets. So this is going on. So this is quite a good progress in this area. And again, the mentorship package was developed, as I have mentioned, and is being disseminated in the counties. So far, dissemination has occurred in 6 counties. 21 counties are planned for further dissemination. We are yet to get the funding for 20 counties dissemination. CPD points have already now been anchored in the Nursing Council and Kenya Medical Pharmacy and Dentist Board in terms of EMOC training, so that it becomes a part of a renewal of the license that we do regularly. And then the other thing that has happened, which is a very major milestone, is that a pre-service task force was formed, which has been overseeing the review of the syllabi in the with regard to EMOC and MPDSR, and this has happened. And 383 lecturers have been trained after the review of the syllabus, both in the midwifery and clinical medicine, what they call the reproductive health curricula. And this review of the syllabus is both in the basic and also the post-basic syllabi. Here is a picture on the left, is the review of the midwifery syllabi, and then on the right is the reproductive health curriculum for clinical medicine, so that we have EMONC anchored already in their curriculum, and this is proven to be sustainable. The in-service training, people forget or people get transferred, but once you train them at the pre-service, then these health workers will graduate with the skills already with them. Now, the other recommendation was improving the blood transfusion services. One of the challenges that was identified with CMD is inadequate blood supply in facilities. Of course, we know blood is an emergency commodity. And here work is in progress, again, between Division of Reproductive Maternal Newborn Health, together with the National Blood Transfusion Services, to remove the bottlenecks that are there in terms of blood transfusion services. And the National Blood Transfusion Services has developed an advocacy and what we call an implementation plan to make sure that the blood transfusion service is providing the adequate service, and also ensuring that there is intensive blood donation campaigns. Counties are also conducting blood donation drives to make sure there is sufficient blood in their counties, and some also have blood banks. But some, as you can see at the bottom there, counties are also coming together to make sure that they develop regional blood banks to ensure adequate blood supply in their counties. The other recommendation was to review policies to ensure the maternity